We are really excited today to have with us Sofia Maitelli, who is actually from the country of Brazil. I met her at the Alzheimer's International Conference, and what she is going to talk to us today is about what we look at when we're looking at brain dysfunction. What is it that we're looking at? What are we measuring when we're trying to tell somebody that they may have a neurodegenerative disease? I'm going to say dementia because that's what you're familiar with. But as we're all familiar, if you've been listening to us for a while, all dementia is an Alzheimer's. And sometimes when you have brain function deficits, it changes how you behave, it changes how you process information. Um, at this time, I'm going to turn our program over to Ms. Sofia Maitelli, who's going to talk to us about the kind of measurements that doctors use to help give us a diagnosis of Alzheimer's or related dementia. Ms. Maitelli.
Hi guys, how are you? So today I'm going to present you, sorry, our research that I've done with other colleagues in São Lucas Hospital, that is a hospital in Porto Alegre, that is a capital of Rio Grande do Sul, the southwest state of Brazil, that is called Executive Function and Memory in Predicting Functionality, results from a cohort of elderly people in southern Brazil. So before I start, I'm going to present myself to you. So I'm a psychologist that I'm working with cognitive behavioral therapy right now, but I also have experience with neuropsychological assessment of older adults. And I also have experience with cognitive stimulation for cognitively healthy individuals and people with dementia. And now I'm doing a specialization in neuropsychology. So, just to give you a context about our research, uh, nowadays we are having like a growing number of elderly individuals worldwide. And with this growing number, we also have an increase on the prevalence of age-related diseases like the neurodegenerative disorders that can progress to clinical stages of dementia. And when you're talking about dementia, we are talking about cognitive decline plus functional impairment. And the cognitive decline basically is difficult in like different abilities, such as memory, attention, executive function, language. This like more like the mental part. And when you're talking about functional impairment, we are talking about this practice parts, like difficulties in performing daily living activities, such as like cooking, driving, doing shopping, things like that. So when a person have dementia, she has problems in the cognition part and the functional part. So our objective with this research was to understand which cognitive domains, like this, which cognitivity abilities were more correlated to functional impairments in individuals with cognitive complaints. So, like when a person have a complaint on memory, which cognitive domains, like abilities, were more correlated to functional impairment. So before I give like more explanations about the research, I'm going to talk about memory and executive function because those are the brain functions that we studied on our research. So memory, it's the ability that we have to encode, store, and retrieve information. In our research, we studied more delayed episodic memory because the instrument that we use to assess the individuals were about late episodic memory. That it's the ability that we have to recall recent information, experiences, events, but we also have different kinds of memory, such as working memory and semantic memory. When you're talking about working memory, uh, we are talking more about executive function. So I'm going to explain the working memory later, but we also have the semantic memory that is more like knowledge, facts, concepts, words. But memory is important for us to functionality because it helps us to remember things that we learn that are helpful for us to like keep working well on daily living, like helping us to remember how to do something or remember our appointments, some instructions, some daily tasks, things like that. But executive functions, they are like more complex because they are high level cognitive process. And when we are talking about it, it means that we have like different abilities inside the executive functions. There are three main components that are working memory, inhibitory control, and cognitive flexibility. Working memory is the ability that we have to hold an information for like a short time, just when the information is needed. So when we need some information, we'll hold that information as just when we need that, and then we will probably forget it. This is the working memory. So it's just temporarily, sorry. Then we have inhibitory control, that it's our ability to resist impulses. Like I want to say something, but I know that I can't say it, so I'm not going to say it. This is inhibitory control. And sometimes in dementia, this can be uh like not working so well. And we have the cognitive flexibility, that it's the ability that we have to adapt to changes and switch between tasks. So when we are doing something and we need to do another thing or two things at the same time, or we are doing like one thing in one way and we need to change the way, it's our ability to adapt. So those are the main components of the executive functions, but we also have like another things such as planning, organizing, changing behaviors. And this is useful for the functionality because allows us to complete complex tasks. Like when we need to like organize a routine, or like we need to organize some trip and we need to like book a flight, rent a car, uh, book a hotel, and knows like the day we're going to arrive, the day we're going to leave. This is all about organizing, planning, and like doing what all we need to do to make the trip go well. This is the executive function. So, talking about the research, well, the sample of our research. So we assessed 465 older adults at the neuropsychology outpatient clinic of São Lucas Hospital, but we included on our analysis just 233 of them because just the 233 match criteria for subjective cognitive decline. That is like there's a complaint of cognitive domains, like there's like complaint on memory, but the performance in the assessment is okay. This is subjective cognitive decline. They also match criteria for mild cognitive impairment, that it's like that it's like a cognitive decline but not functional impairment. And they also match criteria for dementia, that it's cognitive decline plus functional impairment. That's why we use just 233, because they match criteria for those diagnoses. Our demographics also shows that most of them were women, and and more than half of them just completed or just went to elementary school. Talking about women, we can think that maybe it's because at least in Brazil, it's more common for women to look for their health and go to the doctor to see if everything is okay. It's more common for women. And talking about elementary school, this is related to our kind of patients because on the outpatient clinic of the São Lucas Hospital, we just attend patients from SUS, that is the public health system of Brazil. So we have the economic thing and the education thing are really related. So, and we also have one thing that it's we have the like risks of the risk factors for dementia, the modified risks. And Brazil, the most important factor of dementia is it's access to education. So maybe we can think that those individuals that met criteria, the most of them just going to elementary school and just coming from SUS, it's like important data for us to analyze. So here I'm showing you the table that we have. So 47 patients with dementia, being like 29 women and 25 of them going to elementary school. Then 77 with MCI, 56 women and 36 going to elementary school, and then 109 with subjective cognitive decline, being 77 women and 52 going to elementary school. So here we can see that it's not 100%, it's 50.2%. That is because our sample was 465, but here is like just 50.2% that met criteria for those diagnoses. So talking about the instruments that we used the Ray Auditory Verbal Learning Test to measure late episodic memory, because we understand that memory is important to functionality. The Stroop test that assesses executive function, especially inhibitory control. We use also mini mental state examination that it's like a global cognitive screening that can contextualize the other measures, and the Lawton instrumental activities of daily living, that it's the test that can shows us how's the functionality of the patient. So here I'm going to show you the tests. They are all in Portuguese. So here we have the Ray Auditory Verbal Learning Test. How it works. So we have the A list with 15 words. We are going to say the list to the patient and ask him to tell us what he can remember. And then we're going to read again and ask him again. This for 5 times. So A1 to A5. Then we're going to say the list B. That the list B have another 15 words, and we are going to ask him to say to us what he can remember. After the list B, we are going to ask him what he can remember from list A, that is this one, but we are not going to read for him again.
So excuse me, Ms. Maitelli, just for our audience, she's telling you what they're doing in Brazil and in the Portuguese language. We do these exact same tests in English here in the United States.
Oh, okay. Right.
I just wanted to make that clear because these are the same tests that we use. They're just she's got it up on screen in Portuguese, but here in the United States, we do the same tests in English.
Okay. So do you need me to explain the tests, or can I go, because I don't know how much time do I have?
You're doing great.
So, okay. So then after 20 minutes of the list AC, we ask him again the list A7 without asking him without telling him again. And after that, we have the recognition list with 50 words. And then we are going to read 50 words and ask him which words he can recognize. And this is important because here we can see if the patient have difficulties in memory or difficulties in executive function. Because when we ask him to say the word and he can recall, he can remember, but he can recognize on the list of recognition, we can understand that it's a problem in recall, it's a problem in memory. But when we say on the recognition list, and he can even recognize, we can understand that he just don't like hold and can consolidate, he can hold the word. So it's like a problem in executive function, not a problem in recall. Then we have here the Stroop test. It's in Portuguese, but it's like a 3-phase test that the first phase is the patient needs to say what color he is seeing. The second phase, he needs to say, there will be like different words, and he needs to say what color are the words. And then the third phase will be the words will be, the color will be written, but he can say the word, the color, but he needs to say the color, not the word. For example, amarelo in Portuguese, it's a color, it's yellow. But he can say amarelo, he needs to say green. The same thing, azul, he can say azul, he needs to say red. Or he can say laranja, he needs to say blue. This is the Stroop test, but it's in Portuguese. And here we have the mini mental state examination. That is like a lot of different questions about language, memory. Then we ask the patient to draw. We ask the patient to follow commands. It's like a lot of different abilities that we ask the patient. And here we have the Lawton, that it's things more like about the functionality. If he can use the phone, go to different places using like different kinds of like car, bus, etc. Doing shopping, doing their own meals, cleaning the house, things like that. So about the methods of our research, we analyze the data with the software R, and we use the multiple linear regression and the ordinary least squares. I'm going to be fast here. So the results, we have a positive relationship between the Ray auditory verbal learning test and the Lawton. So we have like a relationship, positive relationship between memory and functionality. But in Stroop test and Lawton, we like don't have a significant relationship, and it's a slight negative slope. So we can say that it's like there's no relationship between executive function, especially inhibitory control, and functionality. And the mini mental state examination in Lawton, we can see that it's a positive relationship between the both tests. So when we have like a cognitive global screening and the results of the global screening are good, we can say that the functionality of the patient, it's okay, it's preserved. So about the tests, what can they say to us? Memory can predict functionality, like especially late episodic memory, those recalls, they can predict functionality. Executive function, they are important for us, but they can predict functionality. Like memory, if the person have like a good result in rare auditory verbal learning test, it means that the functionality of this person is preserved, or if there's no good result in the late episodic memory, it can predict that this person will have a loss in functionality. But when we are talking about executive function, it doesn't mean it. Like if the patient don't have like doesn't have like a good result in the Stroop test, it doesn't mean that he will have a loss in functionality. And the global cognition is just like it's just for us to understand that when we have a person with like healthy, cognitively healthy, probably he will be okay in functionality too. So this is important because when we can understand which cognitive domains are more linked with functional independence, we can do like early interventions to slow decline and add like compensatory strategies to that. Because like when you have an individual with loss of memory, with like bad result in memory, and we can predict that this individual will have a loss in functionality, we can start with interventions for functionality, even if he don't have like done any assessment to functionality. But in case of the executive function, it doesn't mean it. But overall, what we wanted to say, the message that we wanted to pass with this research is the importance of we know how the cognitive domains are associated, so we can like predict it and just start with early interventions to slow the impairment as much as we can. That is the objective of all of our research. Now I'm going to talk just a little about our limitations and future directions. The limitations, we only use the Stroop test and assessed only inhibitory control. We just had patients from SUS, that represents the public health care and not the private care. We only assessed memory and executive function, and we didn't use like biological markers, MRI, or another exams. So to the future directions, we can use like another tests for measures of executive functions, like the trail making test, the verbal fluency, animals, that are also executive function tests, but measures another executive domains. We can expand our research to include like private care, and also expand to include another domains like attention, language, social, cognitive, like another kinds of domains. And we can include another kinds of exams, biological markers, or neuroimaging to give like a more comprehensive assessment. And I think that's it, guys. Thank you so much for your attention. I'm very happy to be here. And I will be very happy to answer any questions that you have for me. That's it.
I'm going to start with one of the questions up here. They're asking whether or not what is the association with brain injury or traumatic brain injury? And you talked mainly about executive function and functionality. What are the brain domains or brain functions that are more closely associated with brain injury, traumatic head injury? Okay. Are there differences? I think that's what the question is from Ms. Moore.
So we didn't like study like brain injuries because our research was more focused on dementia, actually. So
brain injury can cause a type of dementia. And so they may have had an injury, but may not be suffering from dementia is what you're answering, right?
Yes.
Okay. Let me see what else is here. Is brain injury, and that's head trauma from having a war injury, domestic violence, or sports related injury, is that the same as dementia medically? And if you remember something we said a long time ago, there are many different types of dementia. Proper term is neurocognitive disorder, and traumatic encephalopathy is one of several types of dementia. Alzheimer's is the one that has been most commonly diagnosed, followed by a mixed dementia, which may be Alzheimer's and vascular disease or Alzheimer's and Lewy body disease. There's a dementia that comes about and is associated with chronic alcoholism. So under the term of dementia, you will have traumatic brain injury. It's just a different type of dementia. And because there are different types of dementia, different brain functions will be affected a little differently. But when you are not able to function and take care of yourself, participate in those activities of daily living that Ms. Maitelli talked about, we give you a diagnosis of dementia. It says I can't hear Dr. Parker. Am I not loud enough? I'm always loud.
I'm hearing you.
Okay.
Yes, we can hear you as well, Dr. Parker.
Okay, turn up the volume, everybody. Okay. All right. Does that answer? That's a good answer. Okay, so on that note, in your country, you talked about public versus private care. Here in the United States, when we talk about public care, people may not be going to a private doctor. They may be going to a clinic that's funded by the government or the county or something. When you talk about private care in your country, what is the difference between private and public care?
So public care is like a governmental initiative to give like access to all of the people, access to any kind of access to any kind of treatment. This is public health here in Brazil. This is what SUS do for us. Like when you need surgeries or any treatment, like for a flu or for something like really serious, we have this for free. This is public care. But we can also, if we have conditions to that, we can like look for these treatments on private care that with doctors that don't do like those treatments on the public care. They just attend on on their own spaces with like for on their own prices, and the people can go if they want to, but it's not needed to. Did I make it clear? Yeah.
I knew you couldn't hear me because I was on mute. Yes, you did
Yes.
make it clear. So you
Okay.
have public care where the care is free in your country is what you're saying to us.
Yes.
And you may have to go to a subspecialist or a private doctor, specialist doctor for certain conditions that wouldn't be offered in the public health space area.
Yeah, but in case, like, if we want to go to a private care and if we can pay for a private care, because most of the services, the public care can give to us, but the point is that different kinds of treatment, we have like a waiting line that it's like really big. So like when you have like a treatment, some people have to wait like 1 year to get it because it's free. So there's like a lot of demand on this treatment.
So for memory problems with the way your brain works and thinking, like what you're discussing today, is that a public offering or private? Does everybody get testing for memory loss and problems like that?
The question is if there like treatment in public and private care. Yeah, in both of them. And neuropsychological assessment in both of them, but it's more common that people like look for assessments in private care because of the line, that this waiting is like really, really longer. I'm not hearing you right now.
I said thank you. Now, okay, I was on mute. Okay, so from this one may not be specifically for Miss Maitelli. It says, what are some common layperson misconceptions about dementia? More specifically, what are possible public health campaigns working on to reduce social stigma? I don't know what the honorable is for, but let me just say that some of the biggest misconceptions we have about memory loss is it's something that is inevitable for people as they get older, and it is not. And just because people have inability to function, have executive function loss, that doesn't mean it's Alzheimer's. It may be something else. And one of the things that we are trying to do with our educational program is help people understand that chronic medical conditions feed into brain dysfunction. So a lot of older adults and even younger adults who have high blood pressure, diabetes, high cholesterol, those are risk factors for developing a dementing illness. So when you talk about public health campaigns, I need our politicians to understand that poor health, access to better health is important for everybody. And it's one of the things that we can do to make it less likely that people develop dementia by controlling those things that we can fix. So access to health care to make sure that we're treating high blood pressure, treating diabetes, which all have a role to play in the development of brain dysfunction and overall health. So making sure that everybody has access to good health care. And if they need specialty care and special testing, like Ms. Maitelli is talking about as a neuropsychologist, we have a mechanism in place by which to get it. So better healthcare access for everybody makes things better for everybody. I hope that answers your question, Mr. Honorable Donald Lee. I hope that helps. Okay, he says he's a juvenile court judge. Well, we'll have to get to that a little bit later, but I just think that access to healthcare is important for everybody, and that's one of the things that you can do to make it less likely that you get some kind of condition like this is to make sure that you don't develop chronic illnesses. So if you've got high blood pressure, if you have high cholesterol and diabetes, you need to fix that. So since we have a circuit judge on here, juvenile court judge, Dr. Trammell, because I know Dr. Trammell is our co-lead for our outreach. And one of the things that he talks about and one of the things that he does is tie cardiovascular illness into how it causes brain dysfunction and results in the testing abnormalities that Ms. Maitelli has been talking to us about today. He said manage those illnesses. So we're talking to everybody, but since you asked, Dr.
Yes, ma'am. How are you? You're muted, Dr. Parker. Speak.
I just needed you to talk to the judge and help him understand we're trying to reduce all the stigma.
Ah, I see. Well, Judge, encourage those young folks to take care of their health starting from a young age such that they do not develop any health issues. And for those of you who are older, if you do have health issues, just stay on top of them, manage them, meaning make sure that you're taking all of the appropriate medications and that you are implementing the lifestyle changes that are necessary for your body, including your brain, to do well as you get older. But on the subject of misconceptions, something that I hear often in my clinic is people have this idea that you get dementia, then you develop Alzheimer's. And it's in fact the opposite. You can develop Alzheimer's, which is a risk factor for memory and thinking loss. Then you can develop dementia, which is the functional loss. So what Dr. Parker was touching on with executive functioning, that Dr. Maitelli, did I say your name correctly?
Yes.
Is covering is people who have issues with high blood pressure and high cholesterol and diabetes, they tend to have executive functioning issues, more so than the memory issues initially. They can eventually go on to develop Alzheimer's because we do know that there is a relationship between the development of Alzheimer's and blood flow to your brain.
Question for you, Mrs. Maitelli. I mentioned that we spoke to you at the Alzheimer's International Conference. That's where we met you. Are you going to be coming to the United States to help us work with people who don't necessarily speak English?
I hope so.
Okay. We're looking forward to hearing more from you and more about your research in executive function and understanding the different ways that healthcare is administered in different countries. And most importantly, you've explained kind of the process, the same process that we do here, using some of the same tools for helping people have measurements, thinking and thought processes measured. So everybody's clapping for you. So I'm going to say thank you, and I'm going to let the end of this be the last comment for Ms. Crystal Davis to tell you what we have upcoming. I know she did a little roll call at the beginning, but let's remind them to register for our Brain Health Forum and BrainTalk Live every week. We can put up the rolling scroll. Thank you, Ms. Maitelli. We look forward to hearing more from you and learn more about your research.
Thank you so much.
Yes.
I love to
Thank
be here.
Yes, thank you, Ms. Maitelli. We thank you so much for an insightful presentation today. And we thank you all for tuning in to another episode of Brain Talk Live. We are excited to be back with you all with
Okay.